Welcome to ATCM, the Emergency Medicine channel. Today we are discussing a case came to emergency room with oncological emergency features. Dr. Manna will be giving the details of the case. Can we start?
Yes, sir. A 65-year-old male patient was rolled into the ER from our ward with complaints of breathlessness and saturation fall. On initial 10-second assessment, patient was conscious, oriented, and was answering to my question.
When a patient comes from oncology ward to our ICU, what are the reasons for acute desaturation in oncological case?
Acute desaturation, in case of any head and neck tumors and all, we should suspect an airway compromise.
Okay.
Then in case of malignancy, advanced metastasis and all, there can be pulmonary, in a patient in ward, patient will be bedridden and all. There is chance of pulmonary thromboembolism.
Okay.
Then allergies to any anaphylaxis to any chemotherapy or medications given. Then
primary lung malignancy anemia can produce.
Seizure possibility.
Seizure, okay.
Then features of SVC thrombosis.
SVC thrombosis, okay. That may not produce breathlessness even, okay. Then cardiac failure.
Cardiac failure.
One of the most common cause for acute breathlessness in patient who is receiving chemotherapy agents is cardiac failure.
And pericardial.
This patient has got brain malignancy.
Yes, sir.
Why brain malignancy patient produces acute breathlessness?
If associated as ADH, aspiration can.
Aspiration, okay.
Then there is a neurogenic pulmonary.
Neurogenic pulmonary edema is one of the important cause for patient who is having raised ICP or even spinal cord injuries can have acute breathlessness because of neurogenic causes for pulmonary edema. It's entirely different from cardiogenic pulmonary edema. That also should be suspected. And patient who is having metastatic lesions on the bones, ribs, they also can have hypoventilation because of the pain. They can also have breathlessness, desaturation. So all these things should be kept in mind when you are treating this patient.
Another common cause which we find is post-chemo neutropenia and sepsis. The earliest cause will be patient will go into severe acidosis and will come with tachypnea only.
Okay.
So in the primary survey, patient's airway appears patent. There was no pooling or gurgling secretion. Patient was answering in one full sentence. Breathing, his respiratory rate was 22 per minute and saturation was 95% with 5 liter oxygen. He was using axillary muscles of resistance. Some subcostal retractions were there. Then bilateral air entry was equal and there was bilateral crepitation, sir. Circulation, heart rate was 108 per minute, blood pressure was 110/70 with a map of 73 and all peripheral pulses were felt equally and bilaterally. Then disability, his Glasgow Coma scale was E4, V5, M6, but there was intermittent fluctuation was there between 14 to 15, sir. Okay. Pupils were bilaterally equally reactive. GRBS was 194 and hypothermia was prevented by blankets, sir. Okay. Temperature that time was 98 degree Fahrenheit. At this point of time, I advised to prop up this patient. Patient was continued on 5 liter oxygen on face mask and ABG was asked. ABG was showing a respiratory alkalosis, sir. Okay. Respiratory alkalosis, lactate was 1 and potassium was 4.1 only. Okay. Only respiratory alkalosis was there. Then chest x-ray was asked for. Chest x-ray was showing right side opacity was there, more in the right upper zone. Okay. Then a screening echo was.
What do you think about this lung opacity?
This patient was hospitalized for the past 21 days, sir. Okay. So it can be a hospital-acquired pneumonia or lung metastasis, but very unlikely because there is no uniform homogeneous
pulmonary embolism.
Yes, sir.
It's also possible. But
only unilateral.
Unilateral can occur. Pulmonary embolism, but since you are telling the lesion is on the upper part, it is unlikely. But even then, we have to suspect. We don't know what is there in the lung. We are only seeing that X-ray. Okay, so that also should be kept in mind.
Then a bedside echo was done to rule out any pericardial effusion features.
Okay.
There was no pericardial effusion. Screening echo was showing good LV functions also. And IVC was 1.2 centimeter collapsible.
Okay.
Then we move to the sample history. There is no known allergies. Patient is a known case of primary CNS lymphoma, which was diagnosed 1 month back, and his status was 2 chemotherapy with vincristine and methotrexate. After the first vincristine methotrexate chemotherapy, patient developed the patient had some extravasation of the.
You should know what are the side effects of these drugs.
Yes, sir.
Side effects of vincristine and methotrexate.
Vincristine, some cardiac side effects are there, sir.
Okay.
It can cause MI, hypertension will be there.
Okay.
Then in methotrexate, prolonged use of methotrexate will cause bone marrow suppression. Sir.
Okay, that is prolonged use in actually in rheumatoid arthritis. Here we are using a higher dose. So even short term use itself can produce bone marrow suppression. So we should be very careful that.
This patient had some chemo drug extravasation, for which he had localized ulceration over the left wrist region.
Okay.
Then this patient, after the first chemotherapy, patient was discharged, and after that patient came back with generalized weakness and intermittent altered sensorium. Then they did a repeat MRI which was showing improvement, and patient responded well to the chemotherapy.
Okay. Chemotherapy was parenteral or any intrathecal was also given?
At parenteral only, sir. Then in the hospital, then he was being evaluated for this altered sensorium, and he was hospitalized. Then in the stay of the hospital, patient developed acute onset of fever 1 day back, associated with breathlessness, cough with dry cough, and in the ward, patient developed a saturation fall, and that time BP, according to the resident who brought the patient, that time BP was in the lower side, sir.
Okay.
But after coming here, there was no hypertension.
Okay. What are the reasons for hypertension in this patient?
It can be sepsis, septic
Okay,
shock.
pneumonia is there, malignancy is there, sepsis is one possibility.
Then he was having generalized weakness, reduced food intake, or sir, hypovolemia.
Okay. Hypovolemia can be there.
Then if he is having some breathlessness because of pericardial effusion and all, if
Okay,
obstructive
cardiac
shock.
involvement can be there.
Cardiac
Pulmonary embolism is
embolism.
another important reason which can
Hypertension.
produce hypertension. Adrenalitis is another important. Most of the patients who is having malignancy on anti-malignant drugs, they can have fungal infection, fungal involvement of adrenal gland. So many patients can have acute adrenalitis and failure, adrenal failure. Fungal infection is one of the major cause for adrenalitis in India. TB is the first one, then fungal infection. But if you take Western countries, it is mostly autoimmune diseases.
Then moving on to the head-to-toe examination, there was no pylorictus, clubbing, cyanosis, lymphadenopathy or edema. On examination of the respiratory system, patient was tachypnic, subcostal retractions were there. Other than that, there was no scars in the chest. Air entry was bilaterally equal, but there was bilateral crepitation more over the right side. Then central nervous system examinations, patient was conscious oriented, higher mental functions were normal. Then power bilaterally, power was 4/5, cranial nerves were normal, and sensation was bilaterally preserved, sir. Then other system, cardiovascular system.
Which cranial nerve you want to concentrate here when you are having a patient with CNS lymphoma? Any cranial nerve can be involved, but as an emergency doctor, which cranial nerve you want to look in?
Raised ICP.
9, 10 is okay, but this raised ICP you are told.
6th cranial nerve.
3rd and 6th. Okay. So 3rd is very important. Okay.
Then examination of the per abdomen examination. Per abdomen was soft, no guarding rigidity. Okay. So in view of in the hospital stay, one chemotherapy was given, sir. Second chemo was given, sir. That time patient had neutropenia.
Okay.
So we are suspecting a hospital acquired pneumonia secondary to the neutropenia, sir.
Okay. So was the patient given any colony stimulating factor? That is
Yes,
very
sir.
important.
Grafil, injection Grafil was
So
given.
that was given before that patient had developed already neutropenia. So patient can have very well an infection during that period. Okay.
So we are suspecting a hospital acquired pneumonia.
How will you define hospital acute pneumonia?
Hospital acquired pneumonia is defined as pneumonia developing after 48 hours of hospital stay.
Is there any difference between hospital acquired pneumonia and healthcare associated pneumonia?
Healthcare associated pneumonia, if a patient goes to a hospital within the past 90 days and if the patient is developing symptoms, it need not be anything associated with the hospital. If a patient is in a nursing home or a patient is having during catheter,
frequent visits to a healthcare facility, it need not fit into the classical frame of 48 hours. Okay. What are the common organisms which we find in hospital acquired pneumonia in our part of the world?
Staphylococcus aureus, Pseudomonas. Gram-negative.
It's more of gram-negative. Okay, it's more of gram-negative in at least in our part. And what are the most common hospital-acquired gram-negative bacteria?
E. coli.
Pneumonia.
Pneumonia.
Klebsiella, Pseudomonas. One of the big three are Klebsiella, Acinetobacter, and Pseudomonas.
Okay.
Continue.
Sir, in ER, the patient was kept in a proper position. Chest X-ray was showing a right side pneumonia. So, in view of previous neutropenias, we were suspecting a fungal or a bacterial pneumonia, and a hospital acquired pneumonia can be there, so gram negative coverage also should be done. So we started with piperacillin tazobactam, sir. 4.5 gram was started after checking the creatine clearance. Creatine was normal, so 4.5 TAD was started, sir. Then patient was given maintenance.
What was the any investigation have you done to rule out a bacterial infection in this case?
Procalcitonin was done, sir. Okay. Procalcitonin was 0.2, sir.
Okay, any blood culture was asked?
A blood culture, a patient was placed on a PICC line like 2 weeks back. So, blood culture was sent from a peripheral line.
What was the report of the blood culture?
That is still awaited, sir.
Okay, what is the percentage of blood culture positivity in pneumonia cases? It's only 30%. So, blood culture is not a reliable diagnostic tool in pneumonia, sir, at least. Okay, but procalcitonin is a very good tool. What is the procalcitonin level?
This patient was 0.2, sir.
So that mostly rules out a bacterial infection, but patient can have very well have a fungal infection or viral infection. Any viral pneumonia is also possible in this patient. Okay.
Especially one thing with procal is you need to go for a serial procal. A single procal at this stage need not.
So any other things for procalcitonin second assay was done?
Actually, you have to repeat after 24 hours. What is procal clearance?
Sir, based upon the RFT.
What I was trying to say is you have a first procal and you have a procal after 48 hours. Okay, say the first procal was 40 and the next procal is 30 after 48 hours. What is the clinical implication of that?
It's responding, but the rate of decrease is very low, sir.
What is the expected rate?
Expected rate is at least half should
50% reduction in 48 hours. Okay.
Reduced.
Okay. Continue.
So blood cultures were taken from both sides. Okay. Patient was started at present. Patient is not having any hypertension, so only maintenance fluids were started, sir. Then there is a wound over the left side, so tissue cultures were taken from that side, sir.
So you want to cover that infection also in
yes,
this
sir.
patient?
Yes, sir.
What organism you suspect in a wound like this?
Staphylococcus infection.
Staphylococcus and anaerobes. It's a typically slightly older wound. Okay, so you can have anaerobes, gram negative, gram positive. Anyway, you are giving piperacillin tazobactam. Better to add a gram positive coverage along with the piperacillin tazobactam. It has got a good coverage, but even then, since there is a skin lesion, it will be okay to add. Okay. Can continue.
Anything else?
No,
Can we come back to the primary diagnosis? You told CNS lymphoma, right?
Yes, sir.
How do you make a diagnosis of CNS lymphoma? And how was it made in this patient?
A biopsy was done, sir.
Okay. So MRI finding?
MRI was showing a left frontoparietal region mass lesion was there.
Is it contrast enhancing?
Contrast enhancing.
It's a contrast
It
enhancing.
was a single
Mass, 2.9 into 2.5.
What are the differential diagnosis for a single contrast enhancing lesion in brain? Meningioma.
Ring enhancing.
Ring. It is ring means around the tumor there is a contrast accumulation.
Brain abscess.
Metastasis normally it will be multiple lesion.
Abscess.
Tuberculoma is one. So lymphoma and tuberculoma is the most important two differential diagnosis. There are a lot of other diagnoses can be there, but a single lesion in our country, tuberculoma is first, lymphoma is always there. Okay, so you have done a biopsy.
Yes, sir.
What biopsy was it? What are the different kinds of biopsies which are done?
This patient, they have taken just a.
Usually they go for a stereotactic biopsy. It's a
Okay.
minimally invasive kind of thing. You need not go for an open kind of biopsy because with CNS lymphoma you are just taking a small tissue. Unlike in other brain tumors where you go for a debulking of the tumor itself, here you are taking a single tissue from there because debulking is not possible in CNS lymphoma also. And any relation between steroids and biopsy?
Before steroids, actually, we should take a biopsy.
Yeah.
Because steroid will suppress the
Tumor.
Especially with CNS lymphoma, it is very easily it will respond to steroids. So the tumor will shrink. So ideally, if you are planning to give steroids, it's better to take a biopsy before giving steroids. And any other investigations? LP, any role? CSF study?
Lymphoma.
We can send for atypical cells, any presence of any atypical cells can be sent.
Now you have while you are approaching, you have an MRI which is showing a single lesion, contrast enhancing lesion. And if there is no signs of any herniation, definitely you can go for a CSF study before the biopsy. Okay, and it can itself show cytology can show features of CNS lymphoma. Okay, can CNS lymphoma present as multiple ring enhancing lesion?
HIV patient, immunocompromised patient.
This is one place where you can get it as both. Most of it is, as you told, it's a single lesion, but it can also present as multiple ring enhancing. For multiple ring enhancing lesion, what are the differentials?
Neurocystic sarcosis. Hydrator.
Toxoplasma, cryptococcal. A lot of infectious things can present. Any relation between CNS lymphoma and HIV?
Primary CNS lymphoma most commonly it is associated with HIV, sir.
Lymphomas are commonly associated with HIV, not primary. Primary can be there in any patient. Okay. What happened to this patient ultimately?
This patient, at present, this patient is maintaining. This patient, piperacillin tazobactam was started, sir. Patient is not having any hypertension. Patient is piperacillin tazobactam. After starting, patient responding well.
What is the chest X-ray finding after initiation of your treatment? Whether it is increased or patient deteriorated in lung part?
Chest X-ray is improved, sir.
Improved. If patient does not improve, his chest X-ray is not improving, what is the additional option for you other than an antibiotic?
Antifungal.
So here you have to even if you don't have a diagnosis, better to add antifungal because its patient is having neutropenia, he is on chemotherapy, he is in ICU, he is in the hospital for a longer period. So there is high chance of fungal infection.
Or negative Procol.
Negative Procol. All these things goes in favor of a fungal thing. But here, if the patient is improving, then we have to better continue the treatment.
One more thing regarding CNS lymphoma, like here it was a parenchymal lesion, or it was a parenchymal brain.
Yes, sir.
Brain parenchymal lesion. So other things might be one of the more common thing will be ocular involvement. Okay, very common. Or else it can be isolated meningeal or spinal cord involvement. Also, CNS lymphomas can be sent. Okay.
Any other paraneoplastic manifestations are there in this patient?
In this patient, no other paranephrosis.
Okay. If this patient develops hyponatremia, what do you suspect?
SAIDH.
SAIDH, more than SAIDH, cerebral salt.
wasting.
More than SAIDH, here you have to suspect cerebral salt wasting syndrome. SAIDH is okay, it can occur, but in this type of patients, the differential diagnosis will be, first one will be cerebral salt wasting. What is the difference between SAIDH and cerebral salt wasting?
Patient will be
normal
euvolemic in
SAD.
SAD,
but otherwise patient will be
hypovolemic. That's a main differentiating feature. Anything else? Okay, so we have completed the case. Thank you.